Hello, everyone. Yeah, good afternoon, everyone. Welcome to today's WRTC seminar series. Um, my name is Bartholomew Chire, one of the WRTC students. I'm here to introduce the guest speaker for today's lecture. He's a physician by training from Colombia, and he has a European master's degree in public health. He recently also completed his PhD studies in the University of Saskatchewan in the area of public health. He has some working experience and research experience in the field of public health, healthcare management, and healthcare policy in a lot of countries. Whilst in Colombia, he worked as a general practitioner and as a healthcare manager, ensuring appropriateness and quality of healthcare services. He also worked in Spain and Poland in the area of coordinating two projects to adapt an instrument to measure career satisfaction of physicians, which subsequently led to a study evaluating the factors associated with higher levels of physician satisfaction. Whilst in Canada too, he has been coordinating clinical research projects of the multidisciplinary inflammatory bowel disease clinic, University of Saskatchewan. He is currently a postdoctoral fellow with the College of Medicine. That is funded by the Saskatchewan Health Research Foundation and the Crohn and Colitis Canada to evaluate the quality of care of patients and with IBD across the province. I'm also happy to announce that he was a former student of the WRTC, and we are happy to have him today as our presenter. Please join me to welcome Dr. Juan-Nicolás Peña-Sánchez to today's presentation.
Thank you. Thank you very much.
Saskatchewan, can you turn off your button? We're just seeing the audience right now. I think someone accidentally touched the button. Okay. If you turned your button on, we're just viewing the audience at the moment. There were two ladies that just came in. I think it's yours. There we go. Great. Thank you.
Well, thank you very much, Bartholomew, and thank you very much to all of you. I'm really glad to be here for the opportunity to present the results of my study. And welcome. So today I was invited to talk about the results of my study entitled Payment Methods and Wellness of Physicians, Dissecting the Impact of Alternative Payment Plans on Equity and Distress of Practitioners. This is the outline that I have prepared for today. First, I'm going to do an introduction to the topic of interest, then enunciate the aim and research questions of these studies, and then present you the methods and results that have been published in 3 different articles, to then gather all the information in the contributions and implications of the studies, to then open the floor for questions and comments. So let's start with payment methods and wellness of physicians. Traditionally, across Canada and North America, physicians have been paid by by fee-for-service. This basically means per each service or procedure, a physician receives a payment. Since the 1990s, different alternative payment plans have been implemented across provinces, Canadian provinces and territories. To understand the differences and the variety of payment methods, we can use the continuum of payment methods. This model organizes all payment methods from the least aggregated end to the most aggregated one, and also classifying them by the unit of aggregation. So we have at the left side of your screen, we have fee-for-service. That, as I mentioned, it is one payment per each service or procedure. And we have the most aggregated end salaries, that the payments are provided for a variety of services, a variety of procedures, and it's paying basically for time. And we have in the middle different options like episode payments, blended schemes, capitation, seasonal contracts, and so on. So in contrast, making a contrast between fee-for-service and APP, first, we need to mention that fee-for-service have been blamed for the fragmentation of healthcare in Canada and in the US. Indeed, a study conducted in Canada from 1998 to 2008 identified that the average annual increase was 6.8 for physician expenses, and more than the half was contributed to the increases in the FFS prices. On the other hand, we have that APP have been implemented. The proportions of APP across provinces are increasing. However, there are concerns regarding declining the productivity of physicians that are paid by these methods. For instance, salary. Moreover, there are studies demonstrating that physicians who are paid by APP have been found to see less patients and to dedicate less time to direct patient care. Based on the available evidence, Dr. Ronick and Durier-Cobb, they find a logic model, and they propose that non-financial factors and payment methods have an incentive effect on behavior of physicians. These affect the healthcare outputs in addition to clinical effectiveness, patient adherence and satisfaction, and subsequently health outcomes. These taking into account internal and external context. To this model, we propose that other factors need to be acknowledged. First, working conditions, which are related to the payment methods as well to the non-financial factors. All of these have an incentive effect that influence the perceptions of physicians in addition to all personal factors. In this study, what was proposed was to study the perceptions of physicians, specifically professional equity, daily distress, and career satisfaction, which are affecting the behavior and subsequently healthcare outputs and so on. Now, this takes us to the wellness of physicians component. It has been demonstrated that lack of physician wellness is an issue that affects physicians themselves, dissatisfaction, professional inequities, distress, burnout, mental and physical health issues. But at the same time, this wellness of physicians is very important because their wellness indicators have been associated with the quality of health services and also that affect patients. There is evidence documenting that inadequate quality of care when physicians experience poor wellness, as well as patient dissatisfaction and low treatment compliance. Now, health systems should focus on understanding this concept of physicians' wellness. And there is a call from Dr. Wallace that healthcare systems performance include wellness of physicians in their indicators. I want to talk now about the first component that was evaluated in these studies, professional equity. According to the professional equity theory, individuals evaluate their own inputs and outputs and create like a rate. And this rate of an individual is compared to the rate of similar others. If there is an imbalance between my own rate and the rate of others, we experience professional inequities. And individuals might be motivated to adjust those imbalances, creating, if there are persistent inequities, could develop distress and more problems. Now, the component of daily distress, it is important because physicians face in their daily practice intrinsic tensions when practicing medicine, facing fear, death, sexuality, and among others, critical components. But there are added sources to the daily practice of medicine, such as deterioration of the clinical autonomy, increases in workloads, practice restrictions, and organizational changes, including a shift in the payment, the way that physicians are paid for their practice. Among highly stressed physicians, it has been demonstrated deterioration of the physician-patient relationship, and also increases in the test orders, as well as a rise in the likelihood of medical errors. Now, something very important is that physicians experience more distress when they perceive that the quality of care that they are providing is low. So we have a cycle of distress that might be affected by external sources. Now, I want to highlight that the gender perspective is very important in all of these aspects. Why? Because the proportion of female physicians has been increasing worldwide, including Canada. Also because the conflicts between work and home play a significant role in burnout, and the predictors of burnout differ by gender. Moreover, female physicians are paid slightly less than their male counterparts, and that young female physicians tend to be paid by APP rather than the traditional fee-for-service. In this order of ideas, I want to present the aim and questions of the studies. The aim of my research was to explore the effects of APP on physicians' perception of professional equity and daily distress. 3 research questions guided my study. First, does professional equity perceived by physicians vary among practitioners paid by APP, fee-for-service, and blended schemes? Second, is the payment method associated with daily distress of medical practitioners? And third, are levels of professional equity, daily distress, career satisfaction of physicians different by payment method and gender? So, the 3 articles that I'm going to present have been published. If someone is interested, I can share the links. Also, you can see at the bottom the reference. So, talking about the research question about professional equity, 4 specific objectives were established. First, to confirm the internal structure of the questionnaire to measure professional equity. Second, to compare the levels of professional equity by payment methods. Third, to identify differences in the levels of fulfillment, income, and recognition dimensions of equity by payment method. And fourth, to test an interaction effect between payment method and group specialty on the levels of distress of physicians. Methods. In 2011, a cross-sectional study was conducted among all physicians practicing in the Saskatchewan Health region. All physicians that were practicing in the region were invited to participate. Only those physicians that were in a residency program or in a leave of absence were excluded of the study. And all of eligible physicians received the survey by mail with an online option offered by email. To conduct this study, corresponding ethics and operational approvals were obtained. The measure of Dobson et al. Was used to evaluate the levels of professional equity of physicians. This questionnaire has 15 items and 3 dimensions: fulfillment, recognition, and equity, and income equity. All of the items scored using 6-point scales, and standardized levels of equity were computed. You can see a sample of the questionnaire in the slide that is presented. The statistical analysis. First, a confirmatory factor analysis was performed to confirm the 3-dimensional structure of this instrument. Second, Cronbach's alpha coefficients were computed for the whole instrument and for each of the dimensions to evaluate internal reliability. And then analysis of variances were performed by payment method for the whole questionnaire and for each of the dimensions. And finally, a linear regression testing the interaction between a specialty group and payment method, as well controlling by the number of patients, representing workload, gender, and age group. So, of the total number of eligible physicians in the region, 48.1% of the physicians participate. That's something very important to highlight because that's a really good response rate, especially if we are talking among physicians. In this sample, the majority were male physicians, 62.6%. Almost a quarter of physicians were paid by APP, 45% by fee-for-service, and by blended methods, 30%. The mean age of in the sample was 49.04 years, and but broad specialty categories, 61% were in medical surgical specialties, and 35.6 physicians were family practitioners. These distributions are very similar to the distribution that we see in other studies reported nationally. And also I want to highlight that bias was checked using a one-page survey. In addition to the questionnaire that was sent to all physicians, in the last mail out, the third mail out, physicians received one-page questionnaire. And those physicians who didn't complete the full questionnaire, we compared their responses, and bias was found to be negligible. So we have a good representative sample for our evaluation. The measure of professional equity, the three-dimensional structure of this questionnaire, of this instrument, was confirmed through the confirmatory factor analysis, and a good internal reliability was identified. The mean levels of professional equity in the sample were 4.09, and when comparing by payment method, we observed that physicians who were paid by APP reported higher levels of professional equity than those that were paid by fee-for-services. In addition, differences were identified in the dimensions of professional equity, specifically in the income and recognition dimensions. As we can see here, physicians who were paid by APP perceived higher levels of income equity as well as recognition equity. Moreover, by specialty group, family practitioners reported lower levels of fulfillment equity as well as income equity in comparison to those to physicians in medical surgical specialties. In relation to the interaction effect, it was identified a significant interaction effect between payment method and the group specialty. As depicted in the figure in the slide, higher levels of professional equity could be predicted among family practitioners who were paid by APP and blended schemes, in comparison to those that were paid by fee-for-service. These differences were not so clearly identified among medical surgical specialties. Now I'm going to move to the results of the second article that it's related to daily distress of physicians. Three specific objectives were established. First, to compare the levels of daily distress of physicians by payment method. Second, to identify payment method and other factors predicting daily distress in a multi-level regression model. And third, to explore an interaction effect between predictors of daily distress and payment method. The measure of Lemner et al. Was used. This is a questionnaire that has 16 items and scores all of the items scoring at 7-point scales. Standardized levels of daily distress were computed. For the statistical analysis, first, the Cronbach's alpha coefficient was computed. Second, an ANOVA by payment method was performed. And then in the multivariable analysis, a two-level regression model, including individual and environmental factors, was built to predict daily distress of physicians. The results. A good internal reliability of the questionnaire was also identified with this instrument. The mean levels of daily distress of physicians was 3.31, and the ANOVAs identified differences by age group, working hours, number of patients seen per week, and weekends on call. Although in this univariant analysis, there were no significant differences by payment method. In contrast, in the multivariable analysis, controlling by confounders and other predictors of daily distress, payment method was identified as a significant predictor of distress, as well as the other factors that I mentioned. In general terms, this model included confounding variables such as regular working hours, time devoted to academic and administrative duties, and gender. In general terms, physicians who were in older age groups perceive lower levels of daily stress could be predicted, Also, among physicians who seen a higher number of patients and were working more than 2 or 3 weekends on call, higher levels of daily stress could be predicted, and career satisfaction was identified as a protective factor. Now, in relation to the payment method finding, it was identified a significant interaction effect between the proportion of patients with complex conditions seen by the physicians and the payment method that they had. Here are depicted the predicted levels of daily distress by these 2 factors, and I want to focus your attention on this part among those physicians who see a higher proportion of patients with complex condition, more than 75% of their patients. Lower levels of distress could be predicted among physicians who were paid by APP in comparison to those that were paid by fee-for-service and blended schemes. Now, to close, I want to present the results of the methods and results of the 3rd article. 2 specific objectives were established. First, to identify differences in the levels of career satisfaction, professional equity, and daily distress by gender and payment method. Second, to evaluate an interaction effect between gender and payment method. The measures, the professional equity and daily distress questionnaires were used in addition to the career satisfaction one. For the statistical analysis, first, multivariate analysis of variances was conducted to take into account that these 3 measures are correlated, and multiple comparisons were performed. The results, the MANOVA identified that the 3 dependent variables were affected by gender, identifying that female physicians reported lower levels of career satisfaction and professional equity, fulfillment and recognition equity specifically, and higher levels of daily distress. The multiple comparisons identified an interaction effect between payment method and gender on the levels of fulfillment, recognition, equity. I'm going to talk about these results. When evaluating the levels of fulfillment, recognition, equity among male physicians, higher levels of equity could be identified among those male physicians paid by APP in comparison to those paid by fee-for-service. In contrast, among female physicians, no significant differences could be identified. Contributions and implications of these studies. It is relevant to understand how payment systems motivate and promote wellness of physicians. Why? Because attitudes, perceptions of individuals influence their behavior. And as I mentioned in the model, this behavior is going to affect the outputs and outcomes in healthcare. And also because behavior of physician has been demonstrated to affect by the payment methods that they have. Now, as demonstrated in this group of papers, professional equity of physicians and daily distress are affected by the payment system that they have, taking into account different factors such as personal, organizational, and contextual ones. In the professional equity component, physicians who are paid by APP perceive better professional equity compared to those that are paid by the traditional payment schemes, specifically in 2 dimensions, recognition and income equity. APP, in this order of ideas, provide a policy alternative to enhance the professional equity of family practitioners and improve quality of primary care indirectly. And prevent the negative consequences like distress. If physicians experience high levels of distress, professional inequities could be triggered at the same time. That's why these 2 factors need to be evaluated at the same time. Now, APP can provide a balance between the contribution and rewards of income and recognition equity. Why is this happening? This could be happening because we are highlighting the importance of the financial and non-financial incentives. Both are important. Unfortunately, managers' healthcare system have been focused on financial incentives. And unfortunately, financial incentives have been demonstrated that the potential to undermine intrinsic motivations of healthcare practitioners, in fact, among physicians. And among family practitioners, a study demonstrated that they have a negligible impact on improving quality of care. And there are studies that they refer that financial incentives have the power to challenge the performance of complex cognitive tasks, such as the practice of medicine. In relation to the non-financial incentives, they have been demonstrated that they can motivate medical practitioners, and they have the potential to enhance the quality of care. So these factors, this evidence need to be taken into account. Now, wellness of physicians is especially necessary among family practitioners. Why? Because financial disparities have been reported between family practitioners and other physicians in other specialties, because poor wellness have been also demonstrated among family practitioners, and because these are not good indicators, they are not good indicators of wellness for those for a group of physicians who should be leaders of interprofessional care and primary health care reforms. Now, in the daily distress component, there is a complex association between daily distress and payment methods. As demonstrated in the statistical analysis, there is not a simple relationship. Different factors need to be taken into account when studying this relationship, individual and environmental factors. Taking into account this, the importance of don't accept this simple relationship, APP have the potential to promote low levels of distress, especially among physicians who see a high proportion of patients with complex conditions, and also to improve the quality of care for these kind of patients who require time. Patients with complex conditions require an adequate time for the provision of care, and also they need enough resources to involve them in the medical decision processes. This is challenging in the traditional fee-for-service schemes. Physicians who are paid by fee-for-service feel the frustration that money rules, and that's something that has been referred in the literature. And family practitioners who are paid by APP can devote more hours to indirect patient care, as demonstrated in one of the studies of Sarma et al., and also to provide direct patient care in other settings than hospital or the office. Now, as I mentioned in the previous slide, when studying distress of physicians, multiple factors need to be taken into account, such as work environment, workload, academic and administrative duties, professional autonomy, career satisfaction, medical specialty, and gender. And I want to highlight this part, the gender perspective. The gender perspective, as demonstrated in the last study, low levels of the professional equity, high levels of daily stress, and low levels of career satisfaction were demonstrated. And also, we mentioned the potential unequal benefit that APP could bring to practitioners, because differences were identified among male physicians, but nothing statistically significant could be identified. Sorry about that. APP could be tailored by gender, taking into account the growing participation of female physicians in the practice of medicine, and also the difference in the wellness that they report, and as well as the professional personal needs of female physicians. Female physicians face additional stressors, such as work and life conflicts, less income, unequal professional success, underrepresentation, and poor wellness indicators. Now, if more physicians, younger physicians, are paid by APP, and the potential benefits on the wellness of physicians is not present, these require further attention and studies and strategies to be taken into account. And APP, in this order of ideas, APP need to appropriate adjustments for female physicians, and studies are needed in this area. Now, limitations of the studies need to be recognized. First, the inherent limitations to the cross-sectional studies. The relationships that I presented are associations. The causal effect cannot be determined, and results can be only extrapolated to physicians practicing in the Saskatoon Health Region, and with caution to practitioners in similar regions like the Regina Coppell Health Region. In contrast, the response rate was very good, adequate in comparison to other surveys, and response bias was checked, providing evidence that the results of these studies are good. In conclusion, enhanced levels of professional equity were observed among physicians paid by APP. Physicians paid by APP perceive fair economic rewards and recognition, specifically among family practitioners. Low levels of daily distress can be predicted among physicians paid by APP who see high proportions of patients with complex conditions. This highlights the potential of APP for improving quality of care of patients with complex conditions. And differences in the wellness of physicians by gender were identified and need to be recognized. Female physicians reported low levels of professional equity, career satisfaction, and high levels of daily distress. The impact of APP on professional equity was only distinguished among male physicians, and this is a finding that needs to also be recognized. Finally, I want to thank the physicians of the Saskatoon Health Region who participated in this study, the staff of the Department of Medical Affairs and the Mercury Research Group, to the WRTC, because I was part of the program and I received this kind invitation to present the results of MS studies, the George and Arlene Lowen Family Bursary, and my professors, supervisors, and also thanks to the Canadian Association for Health Services and Policy Research, because preliminary results of the studies were presented in 2 conferences, and to the Journal of Hospital Administration, where all these results have been published. Finally, thank you to you all for your attention and the opportunity to share the results, and I will be happy to open the floor for questions and comments. Here is my contact information if you have any questions.
Thank you, Dr. Juan-Nicolás.
No. If you want, it's or run out of battery.
Okay, thank you, Dr. Juan-Nicolás. It was a nice presentation on how the different payment method affects the quality of service and affects the physicians especially. And also he used some statistical analysis, which I see, like multivariate statistical analysis using some factor and what are the interaction terms exist there in seeing the physicians' distress levels, and also some confounding analysis. So is there any questions and comments from Regina?
Regina? Greg,
Yes,
you can go first.
Yes, can you hear me?
Yes, we can hear you.
Okay, thank you very much. I have 2 quick questions. One concerns the category called APP and what that exactly means, because it has been generally defined as a residual by CIHI and by provincial ministries, and it's very difficult to know what is included in APP. And I have often found that there is an overlap with what we call blended and APP. And is there a possibility in the future that we could be more precise in redefining a new category that would pin down the type of payment involved and the incentives associated with it? And the second question concerns whether you're able to go back to your original data and split out the medical from the surgical specialties in order to see if there's a difference between the two, given that the surgical specialties tend to be much more transactional and therefore probably in some respects more suited to fee-for-service than the medical specialties.
Thank Thank you very much for your questions. I really appreciate your comments. First, in relation to what we use in these studies about APP, the classification of the payment methods, we basically defined APP as those physicians who were paid exclusively by salary. That means 100%. Other studies use it 90%. In this study, we're 100% paid by salary, capitation, or seasonal payment. For instance, blended schemes included all physicians that had in any percentage that they were paid by fee-for-service and payment methods, APP. For instance, salary and fee-for-service, if they receiving these two types of payments, and fee-for-service were considered only those physicians that were paid exclusively by fee-for-service. For further studies, I agree with your comment that it is important to use different categories, specifically one group for those that are paid by fee-for-service, another one by salary, another one by capitation. That will let us and will allow us to have more clarity of what kind of APP works better and have a different impact. We were not able to identify that in this study due to the number of physicians that we have in this group. Also, it will be very interesting to see the differences that we can have in the variety of blended schemes, because we could have a physician that is paid 50% by fee-for-service and 50% by salary. But in this group, we have also physicians that are paid 90% by fee-for-service and 10% by seasonal contract. So these differences will be very interesting to evaluate them in a further study with more in a differentiated way, with more specific categories. Basically, the idea of these studies were to initially explore what we have in relation of these three groups. In relation to your second question, I find very interesting the idea to compare medical and surgical specialties. When we started the analysis, we have the four groups that were family practitioners, those in medical specialties, those in surgical specialties, and those that were in pathologists or in lab physicians. And we didn't have enough power to keep these categories. We have to merged medical and surgical specialties, because the biggest differences were the variability of the data was when looking to the family practitioners, and that was the first approach. In a further study, a provincial or national one, it will be very important to keep separated these categories. Thank you very much.
Thank you.
Next question. You'll have to press the button in front of you. Okay, thank you.
Mine is minor. Thank you for the presentation. I was just expecting how to see this with different modalities in countries like the developing world, where definitely we don't have such room for different multimodal payment system. That I think maybe we may consider in the future research. But my concern is, you say that the response rate is about 48%. How do you really see this with the power of the study? Because when if the response rate is below 80%, mostly we say that the power of the study is weak. So we know the nature of physician working environment pattern, their busy schedule definitely put them to be largely non-responsive, but overall taking the steady power, how do you see?
Okay, thank you very much for your comments. Yes, in relation to your question about the power of this study and getting conclusions from a sample with a response rate of below 50% generates concerns. However, when you read most of the studies among physicians, the response rates are lower. So, but it is not good to compare with others that were doing worse studies. I think the most important in this study is that we did bias control, and I want to clarify that idea. We sent a full questionnaire to all physicians, 8-page questionnaires, and that's right. You expect that those physicians who didn't participate could have higher levels of distress. or lower professional equity, for instance. To check that, we sent this one-page questionnaire, and we asked them overall, how will you rate your professional equity, the perceived contributions and rewards that you receive, your stress, and we compared the responses of 70 or 90 people that didn't complete the full questionnaire, and the responses there were not significant difference between the two groups. This small group of 70 people could give us an idea of the whole group and allow us to conclude that the responses that we have represent what is going on in the population of physicians. This is a technique that has been used before, used by the Mercury Research Group as well, and I think that let us make more relaxed conclusions that yes, what we found might be what it is in the real world. However, I think that in further studies we need to include different regions to have pictures of smaller regions in rural areas. We have a small proportion of physicians in rural areas in the Saskatoon Health region. Also, we need to contrast big cities and small cities. So I think this is a really good beginning, and the results are reliable given that we checked bias. Thank you.
Okay, the question from Rizana.
Question? No? Not at this time, no.
Okay, thank you. Yeah.
In continuation to the same question asked here, it would have been better if you further distributed or divided the response rate in terms of specialties or family medicine, surgical specialties or so. So for the next step, as you said, you have to plan, or we may plan for further survey, so we can justify where we have to focus more. So here you couldn't distributed specialties response. I mean, family medicine's response rate as compared to surgical response rate, as compared to internal medicine, internist, and so on. So here there is a generalized response rate. And still I believe that this response rate is not very much appreciative.
Yes. That's right.
So if you can give some...
Yeah, I agree with your comments that the response rate varies by specialty. I don't remember exactly all the numbers. For instance, among psychiatrists, that was the highest response rate. I got like 80% of the psychiatrists participated in the survey. That was amazing. Among family practitioners, the response rate was higher too, was about 60-70%. But in contrast, when you look to surgical specialties, it was lower, and there are differences, and that's a really good point because the way that we receive responses from physicians varied. And that will be a good point to review again. I don't have the numbers, but it's good. And well, 40% is not the best, but is what we have, and at least it's some evidence to work with. Yes.
Thank you very much, Nicholas, for the beautiful presentation, and your hard work speaks for itself. I just have a quick question that, as you mentioned, that APP is effective or better than fee-for-service, but does it account for the hours, operational hours of physician itself? Because he, as you mentioned earlier, that a salaried physician does not have that much working hours than fee for service. So does it has effect on reduced distress itself, or because they're working less, so they're not that much stress? That's what I'm trying to ask. Have any analysis done on that?
Yes, we did analyze it because we control it for that. We control it for workload and working hours for the distress analysis, and also in the equity analysis we included a number of patients seen per week. So our results are controlled by that factor. Now I want to comment on what you said, that saying that APP is better than fee-for-service. I think that none of the payment methods are better or are the best. I think each of the payment methods have different characteristics that need to be used in different scenarios. For instance, if we want to increase the number of surgeries, the outpatient, the out-clinic surgeries, we could use fee-for-service. If we want to create a clinic for patients with complex conditions, APP could be a really good option. So I think that when looking and studying and making decisions about the payment methods, different decisions and characteristics need to be taken into account. And I disagree that one payment is better and everyone should be paid like this. That is not a good idea. Indeed, when I came to Canada, I found very interesting that most of the physicians were not paid by salary, because in other countries that I had been, most of them have been paid, we were paid by salaries. So it's interesting, this contrast, and I think this brings a good opportunity for the healthcare system to find the best model of payment methods for different scenarios, and using the available evidence on the impact of payment methods on patients, the healthcare system, and physicians as well.
Anyone here in Regina?
Can we take a question from Regina? Regina. Okay. Regina.
We're waiting for someone to stand up here. I just have one quick question. This concerns the implications of your study for primary care reform, which, as you know, there's been, of course, more experimentation in other jurisdictions, in particular Ontario. What would be the implications for that reform? And second, you talk about the healthcare system, but of course, physician payment is centralized in all provinces through the Ministry of Health, whereas the locus of delivery is through regional health authorities. Would it be better to have the decision-making for the different types of payment systems depending on the type of practice made by a regional health authority rather than a centralized Ministry of Health?
Yeah, thank you for your questions and comments. Definitely, starting from the second question, I consider that the centralization will play an important role on organizing a provision of health services, because let's think about the health region that has majority of its population in rural areas, dispersed areas. The best way to understand how we can provide the services are they know exactly what they need, and they might generate ideas how to implement a specific payment scheme and how to organize the provision of care. If we having a centralized decisions could shadow the initiatives that specific regions could have. And indeed, I find very interesting the idea of exploring different payment methods in different jurisdictions with different populations. That could help to learn this is a successful experience that could be extrapolated to a different one, experiment, and trying to improve based on different experiences. So regions, I think, should have a higher power deciding the payment methods that they are going to have for their practitioners. About experiences in Ontario, I'm not very aware about them, but what I have seen is that the family practitioners tend to be paid different experiences, having done around the world, for instance, with payment per performance. That unfortunately the results are not very satisfying and it doesn't present big improvements. At the same time, capitation is another experiences that have been in place, and some good results can be highlighted, such as now physicians are more interested on how to reduce the visits, how to promote more preventive services, promotion of health. So that's something that needs to be considered as well.
One question from Saskatchewan.
So as you mentioned at the beginning that female physicians usually get less paid compared to male physicians. So, and the participants rate for the female physician was much lower than the male physician. So do you think it actually represented the actual picture, like the stress that equity or professional equity? That's my question. Thank you.
Thank you. Yeah, the proportion of female physicians that we had more male physicians, but when you look the proportion of physicians in the region, the proportion of male physicians is higher than the female physicians. And we compare these proportions, and they have the same distribution. So we can infer that the results could represent the results of the female physicians. And yeah, basically that. So.
Any question from sir? No?
Oh, yeah, we have a question.
Okay.
Go ahead. Yeah, you should be able to just speak. Yeah.
You might have to stand up, though, and direct your voice
Okay.
at the microphone.
Can you hear?
I just have a question regarding family practice. So when you take whether your data set allows you to drill down into family practice, because it can be fairly generic, are you able to sort of drill down into it to see family practice people who have a combination of just office and hospital practice, or those who may be subspecializing in, say, emergency medicine or addictions or palliative care? Did your data show any differences there?
Yeah, really good question. Fortunately, we have that data. We asked it in the questionnaire. We have different questionnaires, slightly different questionnaires for family physicians who were specialized in surgery or in hospitals, as well to those that are in office. So we will we'll have the data to do those comparisons. I haven't done that, but I really like your suggestion, and I expect to see very interesting differences.
Question from Saskatchewan. No more question? Okay. Thank you, Dr. Juan-Nicolás, for your presentation.
Thank you very much to you.